Good morning. I'm going to talk about antibody-mediated prevention of HIV. The place to start is to point out that when a person acquires HIV, antibodies are formed in an attempt to eliminate the virus, but they don't. And so they end up being used for the purposes of diagnosis. But the host does not give up. The host keeps trying to generate, the untreated host keeps trying to generate more and more antibodies until eventually about 20% of people with untreated HIV make what are called broad neutralizing antibodies that will kill many, many strains of HIV, not their strain, but many other strains of HIV. And over time, investigators realizing that they could harvest a single B cell and identify the site at which a BNAb was working, they have identified the sites shown on this slide. And the ones that have attracted the greatest attention for clinical purposes is an antibody from the Vaccine Research Center called VRC01, and there are more recent VRC antibodies, and an antibody from Rockefeller University called 3BNC117. And these antibodies attract attention. The thing that you want in an antibody is you want breadth. It kills lots of different strains of HIV. You want potency. It doesn't take a lot to kill HIV, so it can be used for clinical purposes. And you want it to be able to be generated in concentrations that would allow either clinical trials or product development. So we being the HIV Prevention Trials Network, the HIV Vaccine Trials Network, and the Vaccine Research Center, work together thinking about a proof of concept trial of VRC01, which we thought met the criteria to go forward with proof of concept. The VRC01 antibody is broad. It kills 80 to 90% of all the viruses in a collection generated by David Montefiore, showing it works across clades and has breadth. And it's sufficiently potent that we could give enough IV to generate a blood concentration and a tissue concentration that we thought would prevent the acquisition of HIV. And in order to go forward beyond the aspiration, animal experiments were conducted. And shown here is the idea that if you give the animal a reasonable dose of VRC01 and you challenge the animal with SHIV through the rectum or the vagina, that you can in fact prevent the acquisition of SHIV, SHIV. So all of this led to the belief that we were in a position to do a proof of concept trial of a BNAb to prevent HIV acquisition. And when we were thinking about the trial, we had three kinds of questions. First, is the idea right? Can we prevent the acquisition? Second, is the breadth of VRC01 sufficient to prevent the vast array of strains in a community? And really important, especially for the Vaccine Trials Network, could we establish the concentration of VRC01 required for prevention? Because that tells us what a vaccine would have to do, how much antibody you'd have to make in order to get protection, the surrogate of immunity question. So as many of you know, listening to this talk, we conducted two large randomized complementary trials called the Antibody Mediated Prevention Trials, AMP trials, over several years, in which we infused two different concentrations of VRC01 compared to a placebo every 8 weeks for more than 50 weeks, and to try and answer the questions that I raised on the preceding slide. And to make a very long story short, since it's published, there was good news and bad news. The good news is, well, the idea is generally correct. When you infuse these antibodies in men and women exposed by different routes, you can prevent the acquisition of HIV. But we were able to prevent the acquisition of very sensitive strains that were sensitive in a test tube to less than 1 microgram per mil of our antibody. When the viruses were more resistant, they broke through the antibody. And this suggests to us that we weren't achieving sufficient concentration for the purposes intended, and or that some of these strains were actually resistant to VRC01. And the same idea is shown on this slide, which shows the time of these infusions. And it shows that if you look at the blue, less than 1 microgram per mil, you see very little incidence of HIV observed over the study of these very sensitive isolates. So the glass of water from this study is more than half full for the purposes of the study, but it's not a product, and it was not intended to be a product. It's proof that the concept is generally correct. Interestingly, this is a report by Pegu and his colleagues, who were able to show with all the SHIV data available that you need a really substantial amount of antibody to prevent SHIV acquisition in macaques. And what we learned from the AMP trial is you likewise, if you're using a single antibody, in this case, you need a very substantial amount of antibody, more than we could achieve in order to prevent more strains of HIV from causing infection. So it leads to this heat map generated by David Montefiore and many other investigators looking at different antibodies, and with the idea that if you combine these antibodies into a cocktail, that you will be able to have a product that would be more likely to be successful in preventing HIV strains across clade that are more resistant. And when you look at the red is the desirable thing, where you get the least breakthroughs. And you'll see on this slide that the idea from the antibodies available to us in NIH-sponsored trials are VRC07, same donor as VRC01, but a somewhat better antibody, PGT121, and PTGM1400. These are three complementary antibodies that are attacking the virus at different places and give the best result in a test tube. And IAVI, the organization led by Mark Feinberg, they're really leading the next wave of trials that would, if we move forward, be designed to examine whether this triple drug cocktail could be a product that would prevent HIV acquisition. Now you'll see that we're using not just VRC07 instead of VRC01, we're also using the LS version of this. What is that? That's a mutation introduced into the FC portion to prolong the half-life so that the antibody would be anticipated to last several months. And if this trial goes forward, we'll have to use similar mutations in PGM1400 and PGT121 in order to get the three antibodies to line up to have the same duration of benefit so that we have a long-acting product. We anticipate that the trials of this cocktail might, if it moves forward, would begin in 2022, 2023. Now, it would be wrong to focus entirely on NIH. There are other groups working on BNAbs. And Michelle Nuzenzweig of the Rockefeller has been a champion of two really critical antibodies, 3BNC117 and 101074. On this cartoon, you see they work at different, they act at different sites of the HIV virus. And Michelle and Marina Kasky and others, Dr. Kong, have demonstrated that when you combine these two antibodies together, you get the kind of neutralization breadth that's desirable. You're killing between 80 and 100% of strains. And these antibodies are quite potent. So they've always thought they might be able to give them sub-Q instead of IV. But either way, their potency is comparable to other attractive antibodies. And they went forward, and in their case, they went forward to take people with HIV off ART and show that the antibodies could reduce viremia. And then they combined BNC117 and 101074 and showed that the combination, in the absence of ART, could allow sustained reduction of viremia. And what happens here is as the antibody half-lives occur and the antibody wanes, viremia can recur. Now, I think in some of Dr. Nuzenzweig's work, they've purposefully selected people where they knew the strain was sensitive to the antibody to make it a safer study. So there's a lot yet to do because you've selected your participants. But either way, it's a very compelling result that shows that the idea is correct, that antibodies can prevent the replication of HIV, and then also theoretically, this combination can prevent the acquisition of HIV, as we're trying to do. Now, just like we discussed a few moments ago, the Rockefeller group is introducing the FC mutation to make an LS antibody, long-acting antibody, hoping not to reduce potency or breadth when they introduce mutation. And this just shows a much longer half-life when they make the LS mutations of 1074 and PNC117. So I've now kind of summarized where we are in the United States with antibodies as pre-exposure prophylaxis, but I want to emphasize we cannot work in a vacuum. HIV prevention is an integrated effort that takes behavior change, in this case, safer sex, looks at ART prep and topical ART prep, there's microbicides, vaccines if we had them, and lastly, treatment as prevention, which is a big mainstay of HIV prevention in the United States. So all of our, bad to think in a vacuum, always good to think of integrated prevention strategies. And I would emphasize that everything we've done, most of the HIV investigators, many HIV investigators have been redeployed to COVID, including the PTN and VTN investigators. And Larry Corey and I wrote this editorial at the very beginning of the COVID pandemic, pointing out that COVID was going to require the same integrated prevention as HIV. In the case of COVID, masks were the behavior change that were required, and they really do work in the appropriate settings. Vaccines have proven much easier for COVID than for HIV, which is obviously a wonderful thing. The monoclonal antibodies that surfaced for treatment and prevention of COVID kind of follow in the heels of all the work we did with BNABs. And it was really the BNAB work, a lot of it done by investigators whose names you know, of Bart Haynes and Michelle Nuzensweig and Dennis Burden and others. All that work led us down a path of having COVID monoclonal antibodies that are very important. And lastly, now we're coming up with COVID small-acting molecules that can serve in many different ways, including treatment as prevention under some circumstances. So COVID, like HIV, requires integrated approaches to prevention, and we should thank the HIV field for all the knowledge gained that lent itself to our control and treatment of COVID. So what are the messages from our discussion this morning? Untreated people, people with HIV infection who remain untreated, some percentage will make BNABs. BNABs, many broad and potent BNABs have been isolated, and a few have made it to the clinic. They have both treatment and prevention potential. We strongly believe combinations are going to be required either for treatment or prevention to avoid de novo resistance. BNABs should not be thought of in a vacuum, as I've emphasized in the last few slides. And the big question for BNABs, as we go down this road and put so much time into it, can they really compete with small molecules? So we have excellent small molecules, including the TDF-FTC combination, which is the mainstay of pre-exposure prophylaxis. It's limited by daily use. And so we've seen the pharmaceutical industry move to cabotegravir, an injection every 2 months, lenacapavir, potentially a sub-Q injection every 6 months, islatravir, a pill once a month, or potentially an implant that would last for months to years. So there's a competition out there for this space. And if we're going to go forward with BNABs, we have to make an argument that we can be competitive in this space. Can BNABs be administered conveniently, either sub-Q or IV, in ways that people want them? And can the cost of BNABs be reduced, BNAB combinations be reduced to be competitive with small molecules? So we, at this point, the answer to all this is yes. We think all this is possible, but we're very sensitive to the goal of preventing HIV with the best products available. And BNABs, we hope, we've learned a lot about them. We hope they can make a contribution to prevention. I have borrowed slides from everyone I know. Too many people to thank, so thank you for allowing me to use your slides. All the work I presented required, dozens, scores of investigators, and really patients, as well as volunteers, study participants, who are incredibly generous with their time and their energy, and we want to thank them for letting us learn all we've learned. We also obviously have to thank the funders, some of whom, but not all of whom, are listed on the slide. With respect to the AMP results, we've published a few papers. As I've indicated, we published the primary paper of what we found clinically, but more than 100 investigators are working on a series of reports that would better describe what happens during HIV acquisition and what role monoclonals can play. And I would hope that the audience would anticipate the publication of those papers over the next few months and years. So thank you for listening to this talk. Thanks.